Okay, good evening, everyone. Welcome. So my name is Lakeisha Harris, and I'm the support programs manager here at the Hydrocephalus Association. And I am going to be your host for tonight. Amanda had to take care of some things, so I will be hosting this meeting. I am very excited to see everyone. I see some familiar faces. It's good to see new faces as well. So I would love to start off by welcoming our two guest speakers and introducing them. I'll start off with Dr. David Frim. He is an internationally recognized neurosurgeon and neuroscience researcher who has specialized in the care of children and adults with congenital central nervous system anomalies for over 20 years. Dr. Frim's research and his innovative approaches to treating hydrocephalus, Chiari malformation, tether cord syndrome, and many other conditions have attracted patients and families from national and international sources. Although Dr. Frim is no longer practicing clinically, the neurosurgical team at the University of Chicago Medicine is continuing his legacy in treating patients with all forms of neurosurgical pathology. Dr. Frim continues to be an active medical researcher and educator for the Margaret Hackett Family Program, and also serves as principal investigator on laboratory and research studies related to brain injury, intracranial pressure dynamics, and cognitive outcome after treatment of hydrocephalus and Chiari syndrome. And then our second speaker, Judie Holleman, she's an advanced practice nurse, and she supports both research and clinical care for the Margaret Hackett Family Program. And during her research activities, Judie helps to develop clinical research protocols and clinical trials. While working with patients, she operates as an experienced clinician that helps to interpret and navigate the pathway of care. She brings a wealth of experience and strong commitment to caring for patients impacted by CNS anomalies. So we are so very happy that Dr. Frim and Judith can join us and share their wealth of experience and knowledge with treating patients with hydrocephalus. This is our part 2, so we are continuing the conversation, diving deeper with Judie and Dr. Frim. So just for those, Dr. Frim and Judie, just for those who are new, who didn't join last time, I would like to kind of just go over a little bit of what we talked about last time. We did cover long-term care and, seeking second opinions, malfunction and complication adjustments, and research, many things about transitioning or finding a neurosurgeon team, should I say, that will fit the family. So one of the very common questions that we always have, and I would like to kind of, you guys have touch on this a little bit more. I'll start off with long-term care. What is the chain of command when a child is in the hospital? Should they talk to the head nurse first? What's the chain of command?
No, where's Judie? She's good with that.
Yes.
I'm here. So the structure that we have at the University of Chicago, and everybody does it a little bit different. I guess it depends whether you receive care at a dedicated children's hospital or a community hospital, and how the structure is set up. At our institution, because we're a freestanding children's hospital, and our setup is a little bit different than some. If there's an issue, we would encourage people to call the office. Likely the office receives the phone call and forwards it to the call center patient representatives. The call center patient representatives then would contact either the nurse in the office if it's a scheduling issue or a pretty easy to solve, maybe logistical problem. But if it's a clinical problem, they may reach out to one of the advanced practice nurses or one of the residents, depending on what time of the day it is. And then we would try to field that phone call, either call the parent back or ask the patient representative to tell the parent to come right to the emergency room, or maybe we'll see them in clinic, or maybe we can just watch. Not everybody does it that way. Some other setups are that there might be a nurse and a nurse practitioner or advanced practice provider assigned to each surgeon. So if someone gets care from, surgeon A, they might have to talk to surgeon A's nurse or nurse practitioner. But if maybe you come to the emergency room, maybe surgeon A is not on call. You might end up receiving care from surgeon B in the emergency room, and that might be a different triage setup based on that surgeon's, kind of preference. I think in the community hospitals, you probably end up talking to probably a nurse for the whole office. There may be only just one. And then that nurse would have to provide some kind of triage and a callback. Whether you talk to an actual provider may depend a little bit on the acuity of the situation. If someone's vomiting, super sleepy, and it just sounds like this is a shunt malfunction, you may not even talk to anybody, and the recommendation might be just come to the closest emergency room. That pretty more urgent type response. But I'd love to hear what people's experiences have been in terms of that triage, and how does the phone system work? Because our system is just one way of doing it. We think it works pretty good, but I don't know, maybe there's room for improvement.
Yeah. And please feel free to raise your hand if you would like to comment. But Judy, I do, because I do all of the calls, I take all of the calls, like support calls, and when the parents are definitely, their child is experiencing some issues, whether it be like at home or in the hospital, they're always unsure of what to do next. So I say, well, talk to your neurosurgeon's PA or nurse practitioner. I always say that. So that's good to know that I'm kind of steering them in the right direction. But feel free to, parents jump in and share if you want to. Or just raise your hand so I can see you, because we do have a lot of attendees on here. But Judy or Dr. Frim, when they're in the hospital and they are feeling like they're not getting the care, their child is not receiving the care that they need, or they're just feeling like, hey, something is definitely wrong and they're not getting the answers that they need, who should they talk to?
So if they're hospitalized, then the chain of command should be the bedside nurse assigned to caring for their child or themselves. This is true for adult or pediatric. And if they're not getting the answers from the nurse, ask to talk to a service representative, whether that's a nurse practitioner or a resident or the attending themselves, whoever is covering the service for that day. If they're unavailable for some reason, you can always ask for the charge nurse. Every care unit should have a nurse in charge of that entire care area. And it doesn't, that's true in the emergency room as well, just like inpatient. And if you still don't get the answers that you're looking for, you really feel like you need more assistance, there's always an administrator on call. Now, every hospital might call it a little bit of something different, but it's an administrator. It's somebody at a leadership level that will respond to the charge nurse's request. That's a safety net that's in place for everybody everywhere in this country, and I think worldwide, but I only know about US healthcare.
Yeah. And what if I never encourage, shopping around, right? Like, try to work things out with your neurosurgeon's team. What if they feel like they need to switch, a neurosurgeon or the team? What do they do? What's the best way to approach that?
Oh, I'm not sure there is a best way. I would just say there is a way. So we started, Judy started with, if somebody's not really hitting it off, either with the nurse or with the resident, or if the person who's cleaning the floor or whatever, there's always somebody to go talk to. And sometimes you have to talk to up a little chain because everybody's busy. Most people are quite nice, but they're still busy. And I think that the energy shouldn't be going into frustration, the energy should be, okay, well, this person is working very hard, they're doing something, there's got to be somebody next in the chain of command. And instead of getting angry, it's just to say, okay, can I go see the next person? Who's the next person I can talk to about this? Who can come and talk to, and look at my child's incision? Who can go see why he's throwing up or whatever when his nurse is taking care of somebody else? So that's the first thing I would say, that everybody wants all the children to be fine.
Yeah.
I want all my children to be fine when they're sick. I'm sure everybody's moms and dads, they want to be able to take care of the children. And staying calm, I think that's probably the best thing, is that eventually somebody's going to be around, and eventually the problem's going to get addressed.
Yeah.
And ultimately, if you think of the steps upwards, that you would start with the nurse. He or she's too busy. You would talk to the administrator on call. He or she is going to call somebody else, and somebody else would come. Eventually, somebody is going to be high enough in the hierarchy that that whatever needs to be done is going to be done. And it's just so rare that situation comes, because there are so many steps upwards that someone's going to say, okay, fine, I'm going to go and see what's happening. We'll be right back. We'll look around. We'll call Dr. Frim. We'll do this, whatever. And that's what's going to happen.
Yeah. And is there a scientific, or are there protocols, or is there a precise way to follow a child that has frequent malfunctions or recurring symptoms?
So the answer, I hate to say this, but the answer is probably no, because we can't predict the future.
Okay.
And there are some children who, for whatever reason, they end up with hydrocephalus for some reason, and they end up with a shunt, and so now they have a shunt, and the rest of it is just, I think it's getting used to the idea that there's going to be a lot of people around, and they're your friends.
Yeah.
And that's the biggest part. And I think, and there's so many people. It's almost like the doctors are overwhelmed by all the other people that are working around.
Mm-hmm.
The nurses, the child life people, the people who walk around and, I don't know, give the kids those little bowls of sherbet or things like that. So everybody no one really likes being in the hospital. That's for sure.
Exactly.
And the best thing is, if you need an operation, the best thing is get on it quickly, get the child's operation done, and then everything all of a sudden is now in the upward going and not in the downward going.
Okay, thank you.
That's the way we play the game. I'm sure there's plenty of other ways that work just as well, maybe even better.
Yes. Thank you, Dr. Frim. And Heather D has a question. Heather, you want to unmute yourself?
Yeah. So I guess my question is it common for a child with hydrocephalus to have, I know other conditions can be, but more specifically, like my daughter's facing her 6th year infection. That's not going away easily. And so I'm just curious, is it like more common or anything like that? Or is there any risk involved when they do get those kind of like what would normally be considered like a somewhat minor thing for a normal child versus a child with hydrocephalus, especially with a child who just went through surgery, because she actually just had a revision in January.
Hmm.
And you broke up just a little bit, Heather. Did I hear you correctly saying, asking about ear infections and other kind of normal childhood illnesses?
Yes. Yeah. Like, is it common for them to get more ear infections? Like, is there anything that causes that? But also, is there more risk involved with that, especially whenever they're just out of surgery? Or not just out of surgery, but you know, they've had a surgery within the last 6 months. Hers was in January.
You want me to talk, Judy?
Sure, go ahead.
I'm excited. I'm always excited for this. Heather, how old's your child again?
She is 2.5, so that lovely age where ear infections are somewhat common in certain kids.
So if you look at this is just the United States stuff. There's certainly other ways it's done differently in other countries. But if you think of the United States or, you know, Chicago, big cities and everything, so there's a lot of children. There's a lot of children that are that have different bits and pieces that are just the way they take care of their bacteria, and that can mean that your child may have some sort of affinity to some kind or some family of bacteria, and that may be a problem for her because she may have something that just likes to have a place on her skin, or for some reason there's other things that cause her skin to be somewhat pushed around a little bit by the bacteria. In this situation, we try to make sure everybody has a lot of antibiotics, whatever, when they're having a surgery. That's common sense. However, in this situation, if a child is getting infections around the operations or a few weeks after the operation or whatever, and that now is the problem more so than the hydrocephalus, then that's probably something to talk about with the primary pediatrician, because there may be something that she needs. Maybe she needs to be put on some low level of antibiotics for a little while. That's all very good. That's good for the doctor. But I think that in the overall, there should be some way to knock down on that, on the bacteria, and try to keep the number of the bacteria much lower than it seems to be right now. If she's having an infection, every month or two or something, that's something that you could probably talk to the pediatrician about.
Okay, and it's is it something that is worth, when your child gets something like that, when it doesn't seem to be affected by shunt, it's not like a sign that, I know it's not a sign or anything of the shunt failing or anything, is that something worth even just like telling your neurosurgeon about, or is that something that we don't really need to bother them about? Not that they would need to see her, but just to inform them of it.
So remember, we love to see your patients, right? We love to see our patients, that's you, as much as we can, right? We want to see the patients doing well and everything. And if there's something that's a little bit wrong one way or the other, then usually the best thing is before a patient gets kind of sick is you want to sort of think, well, maybe we want to look into this before something happens. Usually it's a nothing, to be honest, but that's good. It's way better to have a lot of nothings than one big infection. There may be something about your child that, as I say, sort of gloms on to the bacteria, and it may be that it requires some sort of either skin treatment or some sort of low-level antibiotic or something. That may help, because it may just lower the amount of the bacteria, and then she should be able to then start getting a little more strength in her in the skin that's now has its way of killing off the bacteria.
And that question of, is that something worth, bringing to the neurosurgery team's attention? If it warrants a thought or two or three, bring it to our attention. It's a team effort. At least that's our philosophy. And if it concerns you, now it's kind of a bummer, right? That if someone is only 2.5 and you recognize there's already perhaps a series around surgery and a shunt malfunction, I already feel bad about that scenario. But if it crosses your mind and you think, I wonder if these two things are related, it's always worth having the conversation. Sometimes, like Dr. Frim said earlier, people get a little busy. Don't feel like, it's taking extra time. Just say, this is really important to me. I need your attention for 5 minutes on this matter because I see this pattern, or if the medication for her ear infection is costing me an arm and a leg, or I'm really worried that the shunt is somehow related. You'll get our attention. And then it's really important to have that conversation.
Shunts are a great thing. And it's not hundreds of lives have been saved. It's probably tens of thousands of lives have been saved because now we have shunting. And this thing about if somebody has a shunt revision and the wound is open and the wound is when closed again, you might not notice that much, but we're the ones who are sort of now the custodians of the shunt and the skin closure and all of that, because all it takes is a few bacteria in the wound, and then the shunt gets infected, and then the whole story starts all over again. So we have to be very vigilant about that. And so the next part of the sentence is, that means, I guess, that mom and dad have to be very vigilant, because mom and dad are pretty close to their kids. And I think that that's not a bad idea.
Excellent, thank you. So we're going to continue on the path of complications because there are some questions. So I will allow Barry D. He has a question.
Hey, can you guys hear me okay?
Yes.
Oh, you can. Okay. I saw that. Okay. So we have our 4-year-old son, and he has been having kind of like a cyclical vomiting. So like every month or so, he'll have these vomiting spells that almost look like a shunt malfunction. We'll call the neurosurgeon on call and kind of explain to them what's going on. Sometimes it passes, sometimes it goes on and on and on throughout the day for hours. And, depending on the situation, we'll take him in to have, to the ER to have his shunt checked out. And each time it has been not no issue with the shunt. And so, and then he'll be fine. And so he'll be fine, days later, weeks at a time, sometimes even months at a time. So I just was curious if anyone had ever seen that before. We've had a really good ton of conversations with our neurosurgeon, but because he gets better instead of declining, according to what they're saying, it doesn't meet the criteria of a shunt malfunction because he's getting better instead of a steady decline. So does that kind of add up with what you guys see, and then B, has anyone seen anything like that before?
What's the getting better look like?
Just him getting better. So the last one was about a couple of weeks ago. This one was bad enough that we actually again did another ER admission. No shunt issue. Shunt issue looked fine. Ventricles looked fine. And then I would say the next day he got some good sleep. And let me back up one sec. His vomiting is always coupled with being very tired, like sleeping. Yeah, we're talking about you, buddy. It's always coupled with vomiting. I'm sorry, it's always coupled with being really sleepy, like 2-hour naps when he doesn't even nap. So the getting better looks like after he kind of recovers after maybe one more sleep, then he's fine the next day and back to normal and being himself with no issues for long periods of time, sometimes months, sometimes just weeks. Sometimes getting better is immediate after 2 vomits and he is better. Sometimes it takes some vomiting and some naps. Sometimes it takes the next day.
So this what's the best way to say it? So this is something that we see. That's probably the first sentence. This is something that we see, that there are children and they end up with shunts for various reasons, and then they need to have revisions, and so that happens. If that becomes a neurosurgical problem, that's kind of on us, though that's a rare situation, because usually, because of the way the shunts are, we can actually, we take out a shunt from one place, we put it in another place, so it's different skin, all that. And usually that takes care of it, at least for a while. If the situation is continuing, and it's one of those things where it looks like there's an infection and then there's not an infection and whatever, we would probably look at him and in a variety of ways, not just by touching and things like that, but with various sorts of probing instruments, and then say, look, there's something wrong with this child because this is going on and on and on. And at that point, I would probably, I'm not the smartest guy in the world, I would say probably we need somebody to start working up the situation, working up the patient. Is there something, is it some sort of allergy? Is there some other thing that's going on? Is there something about the food that's being eaten? All of that stuff can make exactly those symptoms with this sort of on and off thing. So I think in that situation that I would recommend that that a good pediatrician or a good pediatric infectious disease person might be really the next stop.
The other thing that we look at in this situation where the kids seem to go through a cycle, I like to call it a season, and I wish the seasons were short, and I wish we instantly figured out what the problem was in this season. But it's really common, I think it came up in the last question and answer session, that it's really common for kids to have vomiting or some sleepiness, and it looks like it's the shunt, when in fact it may be related to, I'm way overtired, or I've really, really exerted myself. And so the shunt has been actively draining for a while. And maybe they're just a little bit overdrained, for which they need some good rehydration. But the other thing that can happen is that, especially smaller children or kids that are stressed or going through, maybe finals of high school, things like that, they're not eating very well, they're not drinking very well, they get terribly constipated. Their abdominal pressure goes up, the shunt doesn't drain very well, they act like a shunt malfunction, they vomit, which relieves both their intracranial pressure and it may relieve some of their intra-abdominal pressure, and then they feel better. So like Dr. Frim was saying, if you were our patient and we had seen your son a couple of times with, this cyclical vomiting, my thought would be, like really look at the abdomen, what's happening in the abdomen in terms of the shunt function. And if it looks like the shunt is fully functioning and doing what it's supposed to do, maybe the pediatrician or even a GI specialist would be my next thought. But we in our practice, at least myself and my partners, spend a lot of time talking about nutrition and sleep and really good GI habits. They're not shunt related, but they are shunt related. And so we have one of my former partners, the first question she asked everybody was, how much water did you drink today? Oh, well, you're completely dehydrated. So kids with shunts are more prone to dehydration. And she was, she brought that point home on a regular basis.
That's great to know.
That's great info. Thank you guys.
And so Farah, she wants to comment on this subject before we move on to another question.
Thank you, Lakeisha. I'm hoping is my sound working properly?
Yes. Mm-hmm.
Okay, perfect. I'm just glad that we're having this session, and I wish we had something like that years ago, because in 2015, 2016, my family went through a whole year of investigation to try to understand why our son was having cyclical vomiting, very similar to what Barry has described. And we saw every specialist that we could have seen in the DC metro area. We even shipped his file to Children's Philly, and we didn't receive help until we mailed his medical records to Boston. That's when Dr. Scott there said, I think he's having an intermittent shunt malfunction, even though he's never met my son. But all the doctors in DC, again, we went to all the major institutions, they all dismissed that and thought perhaps we were not well, right? Because we were saying, this is what we're seeing. We're seeing that he's well for a couple of days, then he's sick, and then he's well, and he's sick. And this happened for a year. He had a colonoscopy, endoscopy. We saw a nutritionist. Again, we have a very heavy medical binder for that reason, but the professionals were not listening to us in the area. So I guess the reason why I'm sharing this is to tell Barry, sometimes you may have to go out of state to a new neurosurgeon who's willing to pay a little bit more attention and provide the help you needed. Now, obviously, the shunt revision had to be done locally still, but at least we had that additional professional opinion to help them listen to us locally.
And intermittent shunt malfunctions, this is really, high level hydrocephalus. And I feel bad for anybody in the group who's had to deal with it, because they are really difficult, intermittent shunt malfunctions, because, the kids are kind of fine and then they're not fine. And it seems like we don't do very much and they get better. So then it's really hard to put your finger right on what made them feel better. Just the vomiting made them feel better. It is kind of, I agree with you. It's challenging and it's your child. I'm always a fan of, if you're not getting the answers and you really feel just in your gut and your sense that it may be shunt related, it's worth asking, like in this forum. I think this is a wonderful forum to affirm that you know, the experiences you went through and others have gone through that experience, to go ahead and ask someone else. I love my team. However, I'm not getting my answers. Maybe I need to ask another team the same questions. Maybe they'll hear me differently and get to the bottom of it. But I agree with you. Intermittent shunt malfunctions, they happen, and they're difficult.
Yeah, and I get those type of calls all the time, Judy and Dr. Frim, where they're feeling frustrated. Their doctor, their child specialist is not listening to them, and they know in their gut that it's something with the shunt. Yeah. Okay, so we will move on to Lindsay Saunders.
Hi, can you hear me okay?
Yes.
Hi, thanks so much for this opportunity and for everybody sharing stories. My child is almost 8 and had a shunt placed about 5 years ago and has been great ever since, knock on wood, so thankful. Our pediatric neurosurgeon left our college town though a couple of years ago. And so we've had to get a pediatric neurosurgeon a couple hours away, which is just inconvenient, obviously. And there are neurosurgeons in town, but they're not pediatric. So I was just wondering what folks think about having a local non-pediatric neurosurgeon, or if it's really important for an 8-year-old to have their primary doctor or neurosurgeon be a pediatric neurosurgeon. Thank you.
That's a guild issue that we talk about a lot when we go to the meetings. So I can tell you my thoughts about that, but they're a little bit different from everybody's, because before I stopped, I used to operate on the children and also on the adults. Why did I do that? 1, because I like to operate on children and adults, and 2, because there's really, if you think of it after a certain number of years, that the children and the adults start to look alike. And a lot of things that the pediatric neurosurgeons don't like to do is, I tell them they should try it, because the pediatric neurosurgeons are very good with little things, so they're probably even better with big things. As far as, you know, how good a neurosurgeon you have is something that you would have to get into a little bit. Especially, so let's say you're moving someplace, or let's say that you find that your neurosurgeon is leaving, is that you probably need to look around a little bit to see who's going to be the best neurosurgeon available. There are many adult neurosurgeons who are really great pediatric neurosurgeons. This is without a fellowship or anything. They just seem to like to do the pediatrics, and they probably did it a lot when they were residents, and they probably continued through it. And from my point of view, as long as this, you know, this type of neurosurgeon is available and cautious and has other people that he or she could call up to say, oh, I have this kid and it's this, that, and something. It's just, so there's a little bit of backup. So I would say that it's true. It's fabulous when you have a big pediatric hospital that has a lot of stuff in it and a lot of people and whatever. But that's not most of the people in the country. And so I think that if you're wanting to stay in a smaller area, then you have to do some work to find out exactly what the available doctors are. And it's true, it may be a wonderful doctor, as far as adult surgery, and everyone's saying, oh, he's such a great surgeon, but that person might not want to be operating on children. So you're sort of out of luck. And you have to think about that carefully, because there are nuances between the pediatric and the adult in some ways. So that's something that you need to be cautious about. Not because the neurosurgeons are not great. Almost everybody that's a neurosurgeon is great. We're always the cream of the crop, right? But it's more than that, because every area of medicine has its own ups and downs and things that are very important in each area. And you need to really make sure you have the right person, even if they're mean, but they're good. It's something that you're going to have to get used to.
Thank you.
Thank you. Okay, well,
You can always move to Chicago, though. That's
and I will let Rachel talk, because she has a question on, she wants to talk a little bit about adult versus pediatric neurosurgeon. So it's kind of along these lines. So Rachel.
Thanks. So my question kind of ties into this conversation, but also goes in a little bit different direction. We have a 3-year-old who had 2 revisions in his first year, but otherwise has been stable since. And as the pandemic is beginning to wane, we are now interested in resuming our love for travel, particularly international travel. And so the question becomes, one, is there a good resource of identifying available facilities? And I've reached out to the association and they provided me the resources they have. But then the second, when determining whether or not it's feasible to go to a location, if there's an adult neurosurgeon in country, do you think that is perhaps a sufficient starting point for accommodation in the, hopefully unlikely event a malfunction happens while traveling? Or do you think really limiting travel to close proximity to a pediatric neurosurgeon at this point is really our best course of action and kind of foregoing certain options? Travel destinations, I should say.
You want me to talk, Judy? I like to travel, remember?
Yeah, you're more, international is your thing.
So we in the United States and Canada are very, very lucky the way the medicine is done. I know everybody complains about it, and there's a lot of problems and whatever, but I still think that the U.S. and Canada as a whole is just a really great way to take care of children and adults who have relatively bad problems. So that's good. Then I can tell you that there's all the rest of the world. Not that I don't love all the rest of the world. I have a few friends in Australia. They invite us down every so often when there's a meeting, and that's really great. And we talk about it. And in that situation, in Australia, there's no pediatric neurosurgeons, because that's just the way their system works. And there's usually a group. This is the friend of mine who's the chairman in Sydney. There's a big hospital that we email back and forth sometimes, and he actually is one of the 2 people in his group that take care of the children without a fellowship and all the other stuff. That's just what he did. He started to operate, and there was somebody who was going to be retiring in a year or 2, and that just is what's happened. So there are a lot of great surgeons in the country, in North America and South America and all over Asia, and there's all these Europeans, and there's the density of doctors, density of surgeons in the upper part of the UK and France, going more and more northward. There's a lot of surgeons, and they're all very good, but not all of them are really very good. So that information you have to dig up on your own, or ask your own doctor if they know somebody about that, because that's going to be also very important. There are good neurosurgeons in Mexico, and I have been to a couple of meetings there, and they really know their stuff. So that's good. If my kid fell down and needed to have his skull like taken out and put back in and everything, I'd say, just do it. He says, if he said to me, he knows how to do it, then I would say, okay, fine, let's get going. But there are other places that are going to be different. So you need to have a significant amount of calling around and finding out what are the things that the place where you're going to be, the hotel and the big swimming pool and the boat and everything. You need to be very careful about that, especially if your child is like 2 or 3 years old, because your child's 2 or 3 years old. And that's probably somebody that needs to be treated with a pediatric neurosurgeon.
Dr. Frim, I would love for you to share with me those recommendations for Mexico. I get more than my fair share of calls about Mexico. So, and I'm always like, oh, they do have a good school of neurosurgery, medicine. Look there, but I have no names. So I would love for you to share that with me. Okay. I'll email you. Yes, I'll email you. Judie, did you want to comment on that before we move on to the next question?
No, I think Dr. Frim answered it well. We get this question a lot for people who like to travel and travel internationally. Mm-hmm. I usually recommend, contacting the association, the Hydrocephalus Association, who has a good list. You can look at, like you have somebody put in the chat, the Association of Doctors. But then I usually recommend to people, in our practice, I say, Dr. Frim, who would you recommend? This family wants to go to wherever around the world. But so for everyone on the chat, I would say, talk to your surgeon and say, we're thinking about going here, there, wherever it is that we're going to go. If there's a problem, what hospital should we go to and which neurosurgeon? And, and if you're traveling in an area that there are limited resources, and there are lots of places around the world in which there are limited resources, then I guess it's up to everybody, your personal discretion, whether you want to travel to that area.
Mm-hmm. Yes. Okay. Thank you.
It gets better. It gets better though, because when the child's 12 or 14 or something, that's a great time to have a nice family trip.
Yeah. Excellent. Thank you so much.